Hi, good afternoon, everybody. Thank you so much for taking time out of your lunchtime to join me today. And thank you so much to Mission Hospital for hosting today's webinar. So hopefully the weather's cooling down a little bit for everybody. And then of course, I'm going to do a very short presentation today, but I thought it would be kind of fun to look at an important topic because nutrition is so important, right? I remember just growing up and my mom telling me, you are what you eat. And so there are many common conditions like diabetes, high blood pressure, that we often use nutrition to kind of augment what we do. But the question that I have today is, can we use nutrition as a principal therapy? So as a primary therapy for some common medical conditions that I see in my clinical practice here in GI. And we're going to be highlighting a couple of cases to sort of help us to stimulate some discussion. And they're actually of actual patients that I've seen both in the inpatient setting, so in the hospital, as well as patients that I see in clinic. And so I want to just sort of highlight some of these actual patient cases, and kind of help us to think about how nutrition can help us achieve, better health, help us actually serve as a principal therapy. Because imagine, there's so few things that we do in medicine that has very little side effects, and that's really nutritional intervention, right? Because every medicines that we put patients on, there could be an associated adverse events that could come about, but with nutrition, there's so little adverse events, and potentially we can use nutrition as a principal therapy for some of these medical conditions. Imagine some of the things that we can do to get our patients better. So again, I'm going to be highlighting a couple of cases. So today's learning objective is actually very simple. It's just two. First is identifying nutritional challenges in various medical conditions. And second is understand how nutrition can be used as primary or potentially adjunctive therapy to improve our patient outcomes, right? Not by adding more medicines in, but to use nutrition as a way to improve our patient outcomes. So my first case is something that I see in clinic very often. So I have a 56-year-old female presenting for evaluation of chronic abdominal bloating for the last 5 years. And this patient reports that she actually sees visible distension of the abdomen with some increasing belching. So she belches very often throughout the day. She also has some associated nausea and abdominal cramping. And so sometimes, I have periodic loose stool. And she says, gosh, I try to keep track of all of the different foods that I eat, including lactose and other supplements, but I can't not really identify any particular food triggers that bring about some of these abdominal bloating, the distension, the cramping, and sometimes the loose stools as well. So for her workup, a lot of things were done. So she'd had an upper endoscopy, taking a look at her stomach and small intestine. She also had something called an ileocolonoscopy. So in addition to the colonoscopy, we also went into her small intestine, making sure she doesn't have any evidence of other autoimmune conditions or atypical small bowel infection. She also had stool testing, looking for parasites, looking for other infections of the intestine, and those came back negative as well. And very common when patients come in and complain of bloating, a third of the patient could experience something called pancreatic dysfunction or pancreatic insufficiency. So we sent for a test that's a stool test looking for pancreatic dysfunction. And that turned out to be normal in her case, called the pancreatic elastase. We also did another high-level stool testing called the fecal calprotectin. This allows us to detect even microscopic inflammation in the gut, as potential causes of her overall symptomatology, and that also came back negative. She also had a CT scan of her abdomen and pelvis that was done when she went to the ER because of one of the episodes being so intense, and that came back negative as well. Because the patient, when she saw me, she was actually on a gluten-free diet. Testing her for gluten sensitivity is not accurate based on if you're not eating gluten. So what I did was I did a genetic testing for her, looking at her genetic predisposition for having a gluten allergy or a gluten sensitivity, and that's called the HLA testing, and those came back negative. So because of all of these workup that was done based on her age, based on her presentation, she was given the diagnosis of irritable bowel syndrome. And previously, she was treated with various medications. So medications that we use to help decrease spasms of the intestine, things that help promote better bacterial growth, things that help kind of reduce her overall symptomatology, including probiotics and fiber. And the outcome is that she said, I felt a little bit better, but I'm only 25% better. What additional therapies would be available to a patient like her, thinking about her? So when we look at a syndrome, the irritable bowel syndrome, IBS is commonly called, it's estimated to affect about 10 to 15% of the population. So imagine that 1 out of 10 patient will carry the diagnosis of irritable bowel syndrome. When you look at larger population-based study, the incidence of irritable bowel syndrome is actually thought to even be more like around 30 to 35% of the population, because a large proportion of these patients will go undiagnosed, right? Even though they have symptoms, and they only seek medical care when their symptoms become very significant and debilitating, as in the case of my 56-year-old female that I highlighted earlier. And we know that IBS actually result in very significant healthcare utilization. So a third of primary care visits, based on this large study, was seen for symptoms related to irritable bowel syndrome. And 60% of the visits that come from GI or other specialists are related to IBS types of symptoms as well. We know that there's significant morbidity because of the chronic nature of irritable bowel syndrome, and they also may present with extraintestinal manifestations and comorbidities like anxiety and depression because of the significant symptom, and the fact that some of these patients will report to us that they're really scared to go out and eat with their friends or enjoy a meal with their friend because of some of the significance of their underlying symptom. And among those who are diagnosed with IBS or irritable bowel syndrome, the annual cost to care for those patients is almost $2 billion in the US on an annual basis. So it's extremely expensive. And we also know that pharmacologic therapy, so giving her some of the medicines, they only target at one single symptom, right? Like the cramping, right? Things like nausea, things like bloating. They only target basically a single symptom, or if they have diarrhea, or constipation. And in a lot of the cases when patients have irritable bowel syndrome, as in the case of my patient, she has numerous symptoms, right? So if in order to control all of those symptoms with medicine, we actually have to introduce what we call polypharmacy, which is a lot of medications. And the problem is when we introduce more and more medications, patients will have drug-drug interaction, right? They'll have more adverse events related to the medicines or side effects from the medicine, especially when our patients, like my patient, report multiple symptoms. So that's sort of the limitations that we have in terms of managing some of our IBS symptoms. And 70 to 80% of IBS patients will report that there are specific foods that may bring about their symptoms, right? And ingestion of specific things like specific carbohydrate like fructose or lactose can lead to exacerbation of their underlying GI symptoms in an IBS patient. And certain short chain fermentable carbohydrate called FODMAPs, which are sugars, right? Certain types of sugars are consistently shown to aggravate IBS symptoms when they were re-challenged after sort of an elimination process. So we know that there is a role in diet for management of our IBS patients. So here is an illustration of how the low FODMAP diet could work for our patient. So we know that certain sugars or FODMAPs are not able to be processed by the human intestine because they don't have all of the enzymes to break it down. But what it does is it helps bacteria to break it down, and it also helps it causes patients to actually draw more fluid and salt into the intestine, causing more abdominal distension. And in some cases, the bacteria that takes up some of these FODMAP containing substances, what it does is actually ferment, and it'll create things like hydrogen gas. It'll create methane, so patients actually will have very smelly stools sometimes and more CO2. And overall, this will create a lot more gas, a lot more distension, a lot more cramping in our patient with the irritable bowel syndrome. So in this particular study that was published as a randomized control study looking at low FODMAP and IBS, and you can see here that taking the same patient using the visible annual log symptom score, taking the same patient, and by adding in just a dietary intervention. So this is no medicine, right? Just dietary intervention using the low FODMAP diet. You can see here that across all of the measure parameter, there's at least a 50%, about a 50% improvement in overall symptomatology for bloating, pain, stool consistency by just initiating the low FODMAP diet. And this actually worked for both patients with both IBS diarrhea and IBS constipation as well. So you can see here the overall composite score was a 50% additional improvement by just making that intervention of using the low FODMAP diet over the course of 6 weeks. The good news is that there's additional studies looking at randomized control study looking at intestinal water content as well as gas production by the colon using the low FODMAP diet. And across all of these highlighted study that was published in this meta-analysis and systematic review in 2017 showed that there is at least a 50% improvement in overall symptomatology as well as reduction in colonic gas formation and water content when the low FODMAP diet was applied versus a conventional diet. There are some potential hazards when we put patients on a prolonged low FODMAP diet, because when you're going on that dietary restriction for more than 8 weeks, there could be some reduction in biodiversity, which we know affect immunity, which is why it's really important that when you do that low FODMAP diet to really partner up with a healthcare professional, because we don't want you to go on a low FODMAP diet, you know, for 6 to 7 months without actually being followed closely, because when you do that diet for more than 8 weeks, there could be reduction in biodiversity. There could also be reduction in abundance of healthy bacteria, such as bifidobacteria that we know help also with immunity and gut health as well. We also know that from a micronutrient standpoint, when you go on a really restrictive diet, there could also be issues with overall daily caloric intake. So I actually have patients who are on prolonged low FODMAP diets where they actually have weight loss because they're on such a restricted diet. And we also know that the low FODMAP diet is not rich in iron-rich foods. So sometimes we do have patients go on iron supplementation when they are going on a more prolonged low FODMAP diet. As well as calcium intake as well has also been shown to be reduced when patients are on that low FODMAP diet for a prolonged period of time. So overall, when you do consider some of these more restrictive diets to help alleviate some of your symptoms, it's really important to actually partner up with a healthcare professional to make sure that we're not having some of these micronutrient issues. So overall, my first clinical pearl is that the low FODMAP diet could be an effective therapy for the treatment of IBS symptom. And this is seen in both IBS diarrhea and IBS constipation, as well as IBS mixed features across many randomized control study. In my clinical practice, I typically have patients go on a 2-phase process. The first is the food elimination phase, which we have patients do over the course of 3 to 4 weeks to kind of reset the gut. And then after that initial 4 week elimination phase, I will have them do a food reintroduction phase over the course of 6 to 8 weeks. And during that time period, what happens is a lot of our patients will identify only about 3 to 4 foods in that low FODMAP diet they're unable to tolerate, where the other food groups, if you will, in the low FODMAP diet is typically tolerated. So after that 6 to 8 week phase of reintroduction, hopefully your patients will only identify 3 or 4 foods that they're sort of intolerant to, if you will. So again, that's kind of the first case that I wanted to highlight with an irritable bowel syndrome patient. So I have a case number 2, the I can't swallow patient. So I have an 18-year-old male presenting to the emergency department with a food impaction. So this particular person ate a hot dog too quickly, is what he reported, and it got stuck. But then if you ask his history a little bit more, he said, no, it's actually every time I eat solid food in the last 3 years, I've had the sensation that it gets stuck, or the sensation that it's very slow to move down. The only thing in this 18-year-old history is that he actually has allergic rhinitis, so he has allergy symptom. And he said despite this difficulty swallowing, he really has no weight loss associated with it. And so because of the alarming feature of difficulty swallowing, the patient underwent an urgent endoscopy, upper endoscopy, going through the mouth into the esophagus, stomach, to try to remove the food impaction, as you can see here in this particular picture. And in the evaluation endoscopically, what we saw were actually a lot of irritations. You can see here, there's a lot of scar tissue here in the A, and that's from chronic inflammation healing into scar tissue. If you look further down in the esophagus, you can see also these linear furrows showing that there's a lot of inflammation in the esophagus, and then you can see here the food getting stuck. So this is why we did that upper camera test, is to remove that food impaction so that it doesn't go into his lung, right, because of that food impaction. So what he has, based on the findings from his biopsies and from the endoscopy during the food impaction, is a condition called eosinophilic esophagitis. The incidence is thought to be estimated anywhere between 10 to 57 out of 100,000 patient year. A more updated study showing that the incidence may be a little bit higher, like closer to 80 per 100,000 patient year. And this particular condition is actually a chronic immune antigen mediated esophageal problem that causes inflammation in the esophagus. And then over time, when the condition's ignored or left untreated, they can form scar tissue, and patients can have food impaction. So if you take patients under the age of 20, which we call children, right, in a lot of these studies, when they report with food impaction or dysphagia, anywhere between 63 to 88% of these patients will actually have this diagnosis of eosinophilic esophagitis. So again, happen in young people. I actually, when I was practicing at UCRM, I actually had an Olympian who lost over 40 pounds. 40 pounds, imagine that, leading into the Olympic because of this particular condition that was, again, left untreated. So you can see here that in addition to medicines that we can give as injectables, as well as things like corticosteroids where a patient can swallow, to help reduce inflammation. We know that those therapies can be effective for patients, but there's also a very high risk for disease relapse. And when we talk about young patients, right, and we're putting them on high doses of prednisone or prednisolone or budesonide, which are steroids, there could be side effects that are associated with them, such as risk for cataract formation, risk for diabetes, risk for weight gain, risk for water retention when the medicine's used for a prolonged period of time. So very often, these patients would ask, what are some of the other things that I can do aside from these injection or from swallow steroids that I can do to get my symptoms better? And so here is where the 6 food elimination diet were introduced, and this was studied predominantly in patients younger than the age of 20. So the 6 food elimination basically eliminates 6 different types of food that contain dairy, wheat, soy, eggs, nut, and seafood and shellfish from their diet. And these patients were then followed out to see how things look when we scope them again. So this is a randomized control, this is a control study looking at pre 6 food elimination diet and then post 6 food elimination diet. And you can see here that by introducing the 6 food elimination diet over the course of 4 to 6 weeks, you can see here just in that short time period, there's a reduction in overall inflammation. And when the food were reintroduced again, you can see here that all of the inflammatory cells came back into the esophagus. So we know that this strategy is extremely effective. But for a lot of our young patients, eliminating the 6 food diet can, and by doing that 6 food elimination diet, it not only affects the inflammation as illustrated here in this graph, it also helps reduce their overall symptomatology, such as difficulty swallowing or heartburn, or chest discomfort related to the eosinophilic esophagitis. So again, helping reduce overall inflammation in the esophagus, but also help reducing the overall symptomatology related to that. But for our young patients, really difficult, right, to ask them to actually eliminate 6 foods. So in this other study, this is sort of what we call the step up, which is what we use in our overall practice, where we, instead of introducing that 6 food elimination diet, what we would do is we would actually introduce a 3 food elimination diet. And you can see here that by introducing the 3 food elimination diet, about 40% of the patients will get better. But when you do the 4 food elimination diet, you get about 60% of our patients better. And when you actually do the 6 food elimination diet, about 80% of the patient get better. So depending on the patient's overall symptomatology, we would then recommend either a 3-food, 4-food, or a 6-food elimination diet with goal overall to reintroduce those foods after 6 weeks, because again, for most of our patients, it's really only one of the 6 food group that affects them. So the other question that I often get about eosinophilic esophagitis is that, can I do skin testing to figure out what food I'm allergic to instead of just randomly doing these 6 food? And the answer is that skin testing only picks up 18% of patients with a particular food allergy. The other 80-something% of patients, the skin test will come back negative, or it doesn't correlate with their symptomatology for eosinophilic esophagitis. So in our clinical practice, what we do is basically, again, consider the 6-food elimination diet in patients with more severe symptom, because that's the highest chance to get them to actually feel well in both the adult and children population. But for the patients with more milder symptom, we would consider the step-up strategy of starting off with the 3-food, 4-food, and then escalating to the 6-food over the course of 4 to 6 weeks if they're still having residual symptoms. The other part is when patients have very severe symptoms, sometimes doing the food elimination diet isn't going to get patients quickly enough. And so this is where the elemental diet, where we actually give them specialized milkshakes using peptide-based formula to see how they do in terms of inducing them in remission. This typically works really well, particularly for patients who have weight loss, because they have so much inflammation, they're unable to keep up taking regular food in. So this is where we introduce what we call an elemental diet, which is an amino acid based type of diet. So we pre-digest the food in these type of milkshake. And you can see here that after introducing of this diet, the inflammation cells, right, is very, very dramatic in the group that received the elemental diet versus the group that did not. Okay, as highlighted here. Okay, and you can see also other histological improvement as well, such as microabscesses, which is a marker of how deep the inflammation is also improved by after introduction of the elemental diet relative to not being on that particular diet. And overall, you can see here that placing them on these specialized milkshake, again, these would only be available as prescriptions for selected patients. You can see here, this is again looking at adult population, that overall the inflammatory changes in the esophagus were dramatically improved after the diet was introduced, and the dramatic improvement occur over the course of 4 weeks. And for many of these patients who've had weight loss, they actually were able to achieve weight gain with being on this specialized diet. So again, my clinical pearl for this particular patient is consider starting patients with eosinophilic esophagitis with a 6-food elimination diet, particularly if they have more severe symptoms, and using the step-up strategy, right? Step-up strategy of the 3-food, 4-food, or 6-food elimination diet for those with mild to moderate symptoms. And for more refractory cases, you may consider an elemental diet or even adding in systemic steroids to kind of augment the effect of your treatment algorithm for patients. The next case is something that I specialize in, which is the patient with inflammatory bowel disease. So here I have a Crohn's patient. And again, these are all patients that I've seen in the past, right? They're reflective samples of patients I've seen in the past. So I have a 24-year-old male with a history of penetrating, stricturing, and fistulizing disease with Crohn's disease. This patient, because it's an autoimmune condition, right, where the body attacks the gut, causing inflammation. And here the patient did receive a CT scan where he actually developed internal fistulas on the CT scan. And for this poor 24-year-old, the patient lost over 30 pounds in the last 5 months because of all of the complications related to Crohn's disease. The patient, because of this infection pocket noted on the CT scan, was started on antibiotics. He was also given tube feeding because he lost so much weight, and they were hoping to at some point to take him to the operating room to clean out the intestine because of this significant infection pocket. But because he's so weak and because he lost so much weight, they wanted to really take a little bit of, the surgeons wanted to take a little bit of time to get him better nutritionally prior to the surgery. So we know that Crohn's patient affects about 800,000 to 1 million patients in the US alone. It's a chronic inflammatory condition that's more prevalent in young patients, so patients in their teens and their 20s and 30s, right? We know that because this is an autoimmune condition, it's a progressive disease and it can present with additional complications and risks, as in the case of my patient where he developed an infection pocket when I first saw him. We know that there's certain medications that could help get our patient better, but even the medications that we have, things that block part of the immune system called anti-TNF or tumor necrosis factor blocker, that patients, even if they did respond, almost half of the patient will lose clinical response within the first 12 months. So again, very tricky illness, right, to treat. Even the pet therapies that we have, even after an initial response, some patients, almost half of them could lose response within just the first 12 months of starting the medicine. Right. So what causes Crohn's disease? Well, we don't know what causes Crohn's disease, but we believe that what causes Crohn's disease is that there's an environmental trigger that causes inflammation within the gut. And in the patient that doesn't have the genetic predisposition for Crohn's, they will achieve complete healing. Whereas the patient who has the genetic risk for Crohn's, because of this environmental trigger, and it could be infection, it could be food, it could be from medicine, like antibiotics, for example, that could lead to a dysregulation. And overall, this can cause the development of Crohn's disease. So the question is that, does diet cause a condition like this, right? Does it cause Crohn's disease? And the answer is potentially, because when you look at studies from places that are traditionally at low risk for development of Crohn's disease, like Hong Kong, Korea, and Japan, we see that there's a very low incidence overall of Crohn's disease in the early 1980s, right? But now we're seeing an increasing incidence of Crohn's disease in these area, because as these areas start to become more urbanized, so it looks more like Europe and looking more like US, right, more urbanized setting, we do see an incidence of Crohn's disease in these particular countries to be on a very rapid rise. So there's something in the environment, there's something in sanitation, there is something in that urbanized living, right, that really that as these countries adopt more of a westernized lifestyle, if you will, we now see a very dramatic rise in the incidence of Crohn's disease. And you can see here's a study that looks at basically fat intake and development of Crohn's disease. And you can see here that patients who take in more animal fat or polyunsaturated fat, there's a 7-fold higher risk, 700 times higher chance of developing Crohn's disease versus people who don't have that high intake of saturated fat. And when we look at things like, like PUFA, which is found in fish, right? Fish oil, if you will. You can see here that by introducing fish oil in patients with Crohn's disease, comparing that to placebo, you can see here that the incidence of helping the gut heal with fish oil was much higher than in patients, who were not treated with a fish oil-based type of diet or supplementation. And this is again highlighted in this particular study, again showing that animal fat, which is linolenic acid, or the N6-PUFA, that puts up patients at higher risk for development of Crohn's disease, whereas patients who are on that N3-PUFA, which is found in fish oil, they have a much lower incidence of developing Crohn's disease or colitis. We also know that sugars, simple and refined carbohydrates, right, can also cause things that are in diet, things that like in sodas and whatnot, right, refined sugars, also puts patients at higher risk for development of Crohn's disease, as illustrated here. Again, that higher, taking more things like sucrose, for example, patients who have a high intake of that have a 5-fold or 500 times higher risk for development of Crohn's disease comparing to patients who are on that lower spectrum of refined carbohydrates, right? So it's not just animal fat, but it's also those refined sugars that we take that can also put patients at high risk for development of that risk for Crohn's disease. So with that understanding, there was this study that was looking at basically, instead of using medicine, can we use diet, right? So putting patients on an elimination diet, and you can see here following the patients out over the course of 2 years, you can see here that the group that receive an elimination diet, which is really rich in fish oil and low in animal fat, comparing that to corticosteroids, which is like prednisone, to see how effective is the diet strategy at controlling inflammation inflammation for patient with Crohn's disease. And you can see here, twofold more likely, so 200 times more likely to achieve sustained remission in the dietary modification group relative to prednisone therapy. So again, really, really significant. And we typically do this in our clinical practice to help our patient with Crohn's disease maintain remission. But we also know that being on a restrictive diet could be very, very difficult, right? Especially with young patients, right? Telling them that they can eat only certain things and not other things. So here is a look at what we call a sort of a half elemental diet. So their patients are allowed to eat whatever they like, you know, with half of their calories, whereas the other half they were placed on specialized milkshakes, as in the case. And you can see here that by implementing this strategy, the same pattern was seen, 2 times more likely to actually have sustained remission with their Crohn, so no inflammation in their gut, if they were to be placed on this specialized half elemental diet strategy where half of their calories was with milkshake versus allowing them to eat whatever they like in their diet. So again, really favorable that by doing some dietary tweaking, if you will, we can maintain a lot of these patients with significant inflammation, as in the case of that patient that I highlighted earlier, to keeping that inflammation away and keeping it at bay. Here, we also know that some patients, you know, that dietary intervention is not enough, just like medication is not enough. Can we combine the two strategies, doing medicine as well as dietary intervention? And the answer is yes. So here is a study that I conducted. It's a meta-analysis looking at whether or not using both enteral nutrition, so using specialized milkshake, along with some of the infusion-based therapy for patients with more significant Crohn's disease. And you can see here, same pattern, more than 2 times, so more than 200% likely of achieving remission when patients were receiving both a specialized diet, right, specialized milkshake, and medicine versus just medicine alone. So yes, the diet do matter on how patients respond to therapy, to the therapies that we give them. And also, even in patients, you know, when they develop these infection pocket and they do need surgery to get to clean out the infection pocket, should we do it right away or should we wait? And here in this study, I also published this a couple of years back as well, showing that just by intervening 4 weeks after to their planned surgery, patients actually have better outcome for surgery than patients who did not receive that nutrition supplementation prior to surgery. In fact, they have more than a 70% lower rate of complications in the post-operative setting, and they have shorter hospitalization than patients who did not receive nutritional optimization prior to surgery. So for patients who do need surgery for Crohn's disease because they have complications, can diet help reduce the rate of the Crohn's coming back? And the answer is yes. So this is now, again, looking at a group that received a specialized milkshake that we talked about, where half of their calories were from this milkshake and the other half calories from just normal intake. And looking at patients over the course of 1 year, you can see here the chances of the Crohn's coming back was 2 times less likely, or 50% lower chance, right, in the group that received the specialized milkshake versus the group that did not. So again, a lot of things that we can do for this really significant illness to help our patient beyond just infusing them with medicine, right? There's other dietary intervention, specialized dietary intervention that can be done to make sure that we can maintain them in remission. So my clinical pearl for this third case, and I have one more case, so I'm almost done. Nutritional intervention for a Crohn's patient will depend on the patient's disease severity and presentation, right? We highlighted things that they can do from an elimination diet. We also said that there are some specialized milkshake that can be intervened. And also if in patients who have had complications related to their Crohn's and they absolutely need surgery, preparing them for surgery will not only improve their outcome in the short term, but also in the long term as well. And then we also saw in the studies that I highlight that yes, nutritional intervention can induce clinical remission as well as maintain clinical remission without the need for medications as well. So my last case is actually critical illness. So I actually highlighted this patient because we've seen such a dramatic rise in the last couple of years in ICU admission related to complications from sepsis and COVID-19 infection. So here I have a 64-year-old male with a BMI, which is a body mass index of 42. So this patient's a little bit heavier set, and the patient presents with acute respiratory failure from COVID-19 infection. And because the patient's lung is so sick, he needed actually mechanical ventilation. So he needed to be on a breathing machine, and he also needed medications to keep his blood pressure up. So you can see here in this particular study, it's a meta-analysis that by intervening in this particular patient who is on a mechanical ventilation, by giving them specialized milkshake through the nose, right, and into the stomach, because the patient is intubated, he can't eat, right? By introducing these specialized milkshake, the patient basically have a 30% lower chance of actually dying being in the ICU. So again, a simple intervention, but yet we can have such a significant impact on reducing that patient's mortality. And what's also really interesting is by introducing enteral nutrition, specialized milkshake through where it's fed through the stomach through a tube, we can also reduce infectious complication by 30% in that particular patient, such as hospital-acquired pneumonia and urinary tract infection, right? As well as GI tract infection like Clostridium difficile. We can reduce that overall risk by 30% by introducing early tube feeding in the patient within 24 to 48 hours of hospital admission into the ICU. We also know that there's certain protocols that we can implement in our ICU, and we certainly do that here at Mission, is that, you know, patients who are really, really sick, they may not just tolerate any type of milkshake. So using a more specialized milkshake of semi-elemental solution and then titrating that to a goal rate may allow patients to get the nutritional therapy even earlier, so that the patient can have that clinical impact. And you can see here by implementing that specialized protocol, we're able to introduce more caloric intake as well as protein intake, and we can start the patient earlier within that 48 hours of hospital admission by just tweaking what we do in our protocol for our patient in the ICU. And you can also see here that our patient population in the ICU are getting a little bit more obese. And so, and this is in the study of over 2,000 ICU patients. It's highlighted here that in the US, we're seeing that about 4 out of 10 patients in the ICU will meet criteria for clinical obesity. And so in those patients, we want a milkshake that has less sugars, right? Because that can affect blood sugars. We want a formula that has more protein, and you can see here by tweaking the type of formula that we give or the type of milkshake that we give to our patient, you can see here by just not all formulas are the same, by just making that tweak with a formula that contains higher protein content, the chance of that patient actually dying in the hospital or even 30 days after leaving the hospital is substantially lower. Right? So not all milkshakes are the same, right? So it's also going to matter on how the patient do. And you can see here that really getting that patient, if we get that patient to a sort of a higher level of protein supplementation, those patients are going to have a much lower chance of actually dying in the ICU and beyond 60 days beyond leaving the ICU as well. So you can see here that there are certain formulas that can really help us bridge that protein gap for our patient. So in conclusion, early introduction of enteral nutrition within the first 48 hours of patient arriving into the ICU will improve not only the patient's mortality, but also reduces their risk for overall infectious complication. But in addition to that timing, the formula selection is really important, right? We really want to pick up a formula that has very low sugars and high amount of protein, because this will not only improve both the short-term outcome for our patient, but also the long-term outcome when patients do leave the hospital. So with that said, hopefully I kind of took you through a couple of cases that we commonly see in our clinical practice or in my clinical practice of how nutrition can really improve our patient's outcome.